Hello everyone. Today we'll be talking about auscultation of lungs and identifying different pathological sounds and relating them to specific diseases. So, the rules of auscultation. The auscultation must be performed in a sequence, strictly symmetric parts, and during 2 to 3 respiratory cycles. Initially, listen to the main respiratory sound in normal breathing. Main respiratory sounds are characterized by their localization, loudness, duration, relationship with inhalation and exhalation. Additional lung sounds, these are characterized by loudness, localization, pitch, timbre, and their relation to inspiration and expiration. Besides that, we will also perform provocative tests such as coughing or forced expiration. This will cause provocation of certain pathological lung sounds which won't be auscultated in normal ways. So here this is a typical stethoscope. So at the auscultation point we can see a bell and a diaphragm. So the diaphragm is better perceptive to sounds which are lung sounds. So traditionally we use diaphragm for auscultation of pulmonary sounds. So there are two ways of performing auscultation. Either the fast method, where you can perform bilateral placement of the diaphragm in such manner in anterior chest and posterior view, or if we can be in order to specify the location of the pathology, we can start auscultating along a particular anatomical line. So these are breath sounds, normal breath sounds, and their characteristics. So bronchial breathing. Bronchial breathing is better auscultated on manubrium sterni or in T3, T4 vertebrae in the posterior aspect. Bronchial breathing may be when we auscultate in such points, this is physiological bronchial breathing. However, bronchial breathing can be pathological too. This happens when there is consolidation of lungs. So lungs are able to transmit the sound better, so we'll be hearing bronchial breathing in peripheral parts of the lung. Besides that, bronchial breathing can be either due to atelectasis or it can be due to infiltration, for example pneumonia. Also, a bronchial breathing can be metallic bronchial breathing. This happens when there is open pneumothorax. Bronchial breathing also can be cavital. This happens when the abscess cavity is open to a bronchi. The nature of this sound is like someone blowing air into a bottle. Let's hear a normal bronchial breathing. Vesicular breathing. This is heard due to air moving in and out of alveoli due to vibration of walls of alveoli. As you can see, the inspiratory phase here is longer than the expiratory phase, and the ratio is 3:1. This is normally heard in area where the alveolar tissue is very dense. Vesicular breathing may diminish or it may increase in certain cases. Vesicular breathing may diminish in cases such as pneumonia or the pleural effusion where the lung tissue is displaced, lung consolidation. Also, diminished breathing can increase when physiologically in case when the person is hyperventilating. So this is a normal vesicular breathing. These are pathological lung sounds. Now, rhonchi, this happens when there is excessive mucus secretion in the bronchial tree due to vibratory motion of the wall of the bronchi, as well as movement of mucous membrane inwards and outwards. We can hear a wavy sort of sound. So this is the sound of rhonchi. Wheeze. This is wheeze is differentiated from rhonchi because it happens in a lower respiratory tract. It has more musical tone to it, and it happens during expiration. This can be auscultated during asthma. Stridor happens when there is bronchial obstruction, maybe due to tumor or maybe due to a foreign object. This is sound of stridor. Crackles. Crackles, they are like opening bubbles. Based on their nature, they may be fine crackles or coarse crackles. Fine crackles are heard like so. Fine crackles are heard in case of alveolar edema due to fluid present in the edema. The movement of air causes bubbling of the pathological fluid. Coarse crackles, they happen when there is pathological fluid in cavity of an abscess, which communicates to the bronchi. So it sounds like this. Bronchophony. This is a technique used to identify lung consolidation or maybe the increase in hyperionus of lung. When there is lung consolidation, bronchophony increases. In order to test it, the physician will ask the patient to say the word 99 or in Russia 3 in order to see whether the sound is symmetrical on both sides or increase or decreasing in one side. Egophony, this is done to see when there is whether there is increase in lung tissue or emphysema of lung, or whether there is consolidation. Patient is asked to say E if egophony has increased in one side. It makes the sound to become A. When describing an auscultation, it should be as such. This is an example. Here, this is how we describe the auscultation. Upon auscultating the lung along mid-clavicular line, I heard bilateral normal vesicular breathing. Pathological bronchial breathing was absent. Adventitious lung sounds such as rales, crepitation, and pleural frictions were absent. That's it. Thank you.